Isatuximab is a second generation anti-CD38 monoclonal antibody. We have currently available in our clinical practice several combinations isatuximab-based. That first, IsaKd, Isatuximab, Dexamethasone, that is, in my opinion, the best opportunity that we have in patients in which we want to use in second line anti-CD38 together with the Carfilzomib. Before, the eternal question was Dara or Carfilzomib, but now we have the possibility to use together Isa and Carfilzomib, and I think that for young and fit patients that have never been treated with anti-CD38 monoclonal antibody or are responsive and in some way we want to rechallenge the anti-CD38 with a new drug with the powerful of Carfilzomib, I think that this is an incredible option. We know that it's really important, the prophylaxis for infections. We know that not every patients are able to maintain dose density and dose intensity, but I think that in terms of deepness of response, progression-free survival, but also MRD negativity and the capability of this combination to act almost in the same way also in high-risk cytogenetic patients, this is the best option in second line together with the Pollux, but in lenalidomide refractory patient, I think that IsaKd has in this moment no competitors considering the approved and reimbursed opportunity. The other combination which we are able to use in clinical practice is Isatuximab, Pomalidomide, Dexamethasone. So for patients that are naive for anti-CD38, starting from second relapse, and we want to use Pomalidomide in its best combination, we can use with Isatuximab, and we know that recently has been approved also in Italy, DARA-PD, so we have a double opportunity. IsaPd, we know that has important results in terms of PFS, but also in terms of MRD negativity status. So I think that the idea in second relapse to care also about the deepness of response, so to obtain a response as best as possible, is something of really interesting and something of really new if we compare to some years ago when we had no opportunity in every treated patients. I think that in Isatuximab-based treatment, the best is to come. We know that we will have Ischia clinical trial that I hope will run to approval and reimbursement, and I am particularly positively impressed by IMROD's result. I think that this will be a potential new standard of care in transplant-eligible patients according to the quality of response, to the deepness of response, and also to the tolerability of this combination. So I think that in this moment we are able to use Isatuximab only starting from first relapse, but in the future this will become the backbone also in frontline treatment, I hope, for both transplant-eligible and ineligible patients. Moreover, some combinations are going to be explored in my institutions. I have a phase 1 umbrella trial in which new molecules are being combined with Isatuximab, also in terms of rechallenging, because I think that another unmet medical need is to understand if the rechallenge of anti-CD38 antibody, particularly for the patients treated with daratumumab and responsive to daratumumab in front line, if a combination is Isatuximab-based has sense. Maybe in patients that achieved a very good response and a long-term response, I think that rechallenge with another agent could have a very good sense, and I think that real-world data will answer positively to this response, but we need to collect, and I think that also MRD is another parameter that we have to care, and I think that according to the brilliant data that we had with the Isatuximab regimen in clinical trials, we have absolutely to integrate MRD evaluation in our real world in order to better understand how much Isatuximab functions in our patients, in order to have a very good endpoint to evaluate, particularly in young and fit patients.